Essentially, internship
which is
for
training.
the workforce, which is part of training, is supposed to be a function of the national government. It used to be a circle. So internship was the entry point. From internship, 1 year, you serve for a period 3 to 5 years. You then apply for study leave. You go back to school. You specialize. You come back. And once you specialize, then now you offer specialized care in all facilities. So once you've specialized and you're in government employment, you choose whether you want to exit
or remain.
And you can exit at whatever point of this continuous cycle. But devolution then now broke this cycle between internship and employment. That gap.
Hello, welcome back to season 2 of the One Health Lens podcast, where we have conversations about health and related topics, making them simple and easy for you to understand. I'm your host, Dr. Dana Wangari Gitao.
And I am Dr. Simon Moshara Kigondu.
He too is back. Today we're having a conversation around labor relations in healthcare. I mean, we've had conversations around universal health coverage and Kenya's road to universal health coverage. And a big component of that is the human resource for health. That the people who offer you these services are qualified, well-trained, and highly motivated. This is the conversation we're having today. In studio with us, we have, as always, a very important guest who will introduce himself and we'll get going.
Thank you. And my name is Dr. Chibanzi Mwachonda. I am a medical doctor. I'm also a labor expert in matters labor. And more specifically in the health sector, because that's one area that I've really had a lot of experience and expertise and training on in the past decade, I'd say.
Yeah, more than a decade. I mean, I was in medical school when you're in the medical union, so it's been quite a journey. Yeah,
it's been quite a journey. Yeah.
Absolutely, and I'm glad you're here.
Thank you.
I mean, the conversation around human resource for health is not an easy one, right? Because like most things, it's first you're dealing with human beings, right?
Yes.
In a very complex system, right? And so there's a history to this, right? Most people will say that doctors, we just hear them when they're on strike demanding for, pay, right?
Yeah.
Or promotions, right?
Yeah.
Yet it's not something that doctors wake up and say, we are going on strike, right? How far back can you take us, right? Where do we start?
Well, I think if we're to handle the issue of strikes, we can go back as far back as, pre-independence and independence.
Oh boy, okay, let's not go that far back.
Go that far.
No.
I think the main point here is the agenda of universal health coverage. I think it's post the 2000 era that now it became a global agenda on universal health coverage. And one of the key pillars of UHC is a well-trained, well-motivated health workforce. And as you said rightfully, human resources, it's people. You're dealing with people, it's livelihood, it's careers, And it normally gets very emotive. And it's a lot of the mixed bag.
Absolutely.
Yeah. So I think I'd like to maybe say what has been Kenya's experience in the last decade.
Okay.
Let's start with 2014.
Okay.
And specifically because at that point, something significant happened in this country. Devolution.
Ah, yes.
Yeah, so devolution post the 2013 election was effected on February 14th, 2014. That's when now human resources had to be devolved down to the counties. The labor sector unions in the health sector had gone on strike prior to that in December 2013. There'd been other strikes, of course, before that. I think the 2010 constitution opened up the forum for labor rights and Article 41, subsection 2 of the constitution. And that's when unions in the health sector are registered, the first one being Kenya Medical Practitioners, Pharmacists and Dentists Union. That's where us as young ones are really now use that avenue to advocate for change in the health sector through the Human Resources for Health. So yeah, the union existed then, and that's when it came into existence. 31st August 2011 is when it was registered. So first strike in 2011 on pay, as usual, and of course there was a myriad other issues that other reforms were tabled and proposed. There was a Musimi Task Force report on health, human resources, and other functions in the health sector. But let's now come back to 2014, where devolution took place, and at the same time something significant happened, because there had been 3 years already of agitation by the health workforce. The Kenya Human Resources for Health Strategic Plan by the Ministry of Health 2014 to 2018. That came now, that at least would like us to start the basis for which the Kenyan government and the Ministry of Health then now puts its commitment towards human resources for health, that is the health workforce, and now aligning this with achievement of universal health coverage.
Okay.
So that's how I'd...
Okay.
Yeah.
So, I mean, devolution, what's the word? Devolution happens. But, okay, so initially it was that health workers or the health workforce was managed centrally, right? Nationally, right? Yeah. So both from recruitment to deployment, all elements of HR matters health was national, right? Ministry of Health, right?
Yes.
So devolution, that means then counties have the power, so they have to recruit, and most functions outside the, I believe it was the internship matter, were deployed now from county. Is it, right?
Yeah. So this is how it's structured. In the Constitution, Schedule 4 of the Constitution, you have devolution in terms being defined in terms of what are the levels. So there's training, policy, and capacity building. That's a function of the national government. That's through the Ministry of Health. Then health services delivery was now devolved to the counties. You see, your co-host here went to court on that issue, and what they were challenging, it makes sense, because when it said health service delivery, it wasn't explicit.
Yeah.
So what was decided was that level 5 and 6 hospitals would be retained at national government. Then level 4 downwards would go to the county level in terms of management. Okay. So I think that's the genesis really.
Yeah.
And from there, then two things happened. One, there was the autonomy of the counties to employ and dictate terms of service and employment of the health workforce.
Yeah.
Then the second thing was that the national government, through the ministry and the national teaching and referral hospitals, and then the policy function and training function were retained at the national government. So essentially, internship for
training.
the workforce, which is part of training, postgraduate training for those who want to specialize across all health cadres, not just the doctors, because even clinical officers do specialize in their own right.
Yeah,
it's supposed to be a function of the national government.
Yeah.
So I normally say it used to be a circle, that if you were to draw arrows of a circle from one stage to the next, you'd complete it.
Yeah.
So internship was the entry point for the health workforce, for the doctors, for the clinical officers, and all other health cadres. From internship, 1 year, you become, let me use the doctor, you become a medical, dental, or pharmacist, dental officer or pharmacist. You serve for a period 3 to 5 years. You then apply for study leave. You go back to school. You specialize. You come back. And once you specialize, then now you offer specialized care in all facilities. So for me, it was a complete circle.
Yeah.
So once you specialize and you're in government employment, you choose whether you want to exit.
Yeah, or remain.
And you can exit at whatever point of this continuous cycle. But devolution then now broke this cycle between internship and employment. That gap. Because counties then demanded to have that they had autonomy to dictate and hire the health workers that they wanted, including doctors that they needed.
Yes.
And I think that was one of the biggest challenges during our time in the doctors' union. Because on one end, counties governments kept insisting that we will dictate.
Yes.
We remember we are coming from an era of you post them to
Yes.
the counties.
Yeah.
So we have a number of doctors trained as coming in as medical officer interns, and after that they need to be employed. So there are gaps in the system, but then now there are no resources, and I think that was the genesis of the last industrial action by the KMPDU. And it became a big debate, for 56 years, and that's what we there was a back and forth on that. And I think
56 days.
it
felt like years, I'm sure.
So that's the whole point. And so what are the commitments that the strategy has put in paper? One is to ensure there is equitable distribution of health workers across the country. So that means if you're in Turkana, you should be able to get services the same way you'd get services in Nairobi. Comprehensive services from the lowest level, that is a community health worker, or they call them, what do they call them nowadays?
Community health promoters.
All the way to the specialists at that high level. You see. The second one was that capacity development, that is training and career progression for the health workers. So the doctor, the clinical officer, all have an opportunity to progress career-wise. You decide you'll go the clinical pathway, the research pathway, the public health pathway, but at least there's that opportunity that as you work, you get a study leave. After that, you go and then the third thing is, apart from the development, is that you allow the health workforce to also move across the country. So it transfers. Those were things that were very straightforward. But then now, as we speak with the counties, it's a bit difficult. You hear cases for the last 10 years of I want to move from county X to county Z, but I must get someone on that side who wants to come to this side, so that then now we swap. And you see that in public, in the public sector. That's not what public sector practices and HR policy manuals by the Public Service Commission dictate. You see, transfers are supposed to happen across board. And now these are the things that eventually boil down to the unrest we see in the health sector, because there are labor issues. As you said, they're humans. They have lives. Movement should not be limited by work. You can move from one point to the next. And especially within government, being that government is the biggest service provider of healthcare services, not the private sector. It's government, you see. And that's a mandate of the government, because they collect taxes and they offer services. So these HR practices and management is where the crux of the matter has been for the last 10 years. And what is its impact on UHC? Because if we lack this, then are the workers, are they content? Are they motivated? According to what UHC dictates. I think that's
the nuts and bolts of it. I mean, you know what I always find, and what I even like in terms of just how you described it as a cycle, right? A cycle, right? Because in many ways, if you think about it, you want to be able to say, okay, I have studied for whatever X period, right? And those, it doesn't matter whether it's 5, 6, or 7, because I think sometimes we, or rather from a public perspective, we as healthcare workforce, so to speak, have not been good at communicating the issue, right? Because it's a factor of we studied for 7 years, so we require preferential treatment. That's what the public hears sometimes, It becomes a factor of because we studied for X number of years, then we require a certain kind of pay, right? And then in that case, the postgraduate training, the internship period becomes, it's a factor of they're also doing attachment, so it's equalized to, say, any other sort of professional. However, what I think, and back to the cycle, it's for you to have quality, right? It requires that what you're taught, you are able to apply, right? That number one. But that application is not a factor of what do you call it? It's a fact of you've come out of school, you've gone into an internship to practice, but more importantly, it's progressive, right? So you know that after these years of practice, and say, for example, I was in Muranga, Turkana, as you said, and I realize I'm here and I require, maybe in Turkana, what requires more surgeons as an example, I can easily first apply for training in surgery without having to worry about, okay, what system do I need to go to and whatnot. It's a continuous loop. So, okay, I'm training in Turkana, surgeons are required. I can make an application, go to school, get study leave for that, then come back and feed into that system, right? If you're using the Turkana surgery example, right? Without going into even too many technicalities. So that if you're looking at it from then the how does solve the public benefit, you want to know that if a doctor is here and there is need and they require specialty training, they can easily do that, right? If, for example, you have specialized and required, okay, fine, perhaps I need to move. Maybe it's just family reasons as well. I got married, my partner is here, my children is somewhere else, I need to move as well, and this is where the human element comes in. Then I should be able to move, right? So then I'm not worrying about finishing my surgery immediately so that I can rush home and then come back tired after 2 days of seeing my family, right? So again, it's complexities of saying, okay, if there's freedom in terms of how we are able to progress in terms of healthcare workers, right, then you're able to bring out that quality, that motivation, right, even before you talk about pay and whatnot, right? So that cycle was interrupted because then devolution comes in and says, no, capacity building policy remains here. Then counties, everyone comes with their own sort of plan, right? And apparently Kigondu went to court. Kigondu, why did you go to court?
Twice.
No, twice. Why did you go to court?
So, and thank you very much. And it's good we have Dr. Mwachonda here who... maybe he has not told you, but over and above the small things that he did, he actually went for a 6-week intensive training in South Africa on labor matters. So his understanding may be slightly at a higher level than all of us.
Than the rest of us, for sure.
Yeah. But when you look at human resources for health, history is very important. And we start with the strikes. There was the 1972 strike, 1971 actually, that Dr. Aluoch claims he was jailed for. Then we had the 1981 strike. In the Moi era, we had several strikes, 1981. And then we had the 1994 strike. In 1996, KMPDU was actually formed. But in those days, in the Moi era, as in you couldn't have a union for health workers. It was put as an essential service that cannot go on strike, and that was what was used to sort of put down people and keep them at their level. In the strike of KMPDU of 1996 never ended, and we had people leaving the country. Ateka eventually went. South Africa died recently, but they never came back, and that strike has never been called off. So we ask those who called that strike to actually call it off.
In 1996.
It was never called off. I did a paper on strikes in the country, and the only decade where there were no strikes in Kenya was the decade 2000 to 2010. And why? When you look at it, that is the period that Kenya Medical Association actually came up with a paper that tried to solve part of the problem that we are having in the medical practice. The doctors working in public sector are put in civil service job grade structures, and some of the nuances in medicine, in medical practice, are not put in that job grade structure. And that's what the Kenya Medical Association at that time played around with and brought the first document that the first request for pay rights, so to speak, just to bring some dignity to the pay, was rejected on the basis that that would have a big impact on the civil service wage structure. So they went and looked at what is unique to health, and that particular time was mainly doctors, let's put it that way, but it applies to several other cadres at various levels. And they went and looked at risk allowance. A doctor treats people with TB, can get TB, is at risk, can get HIV. Yeah. Then extraneous allowance. Their doctors work at night, in danger, I suppose you have to go. So that was included. And non-practice allowance. That was generally put to increase the pay, not necessarily because the non-practice allowance, because we don't think they can pay us enough non-practice allowance, but that helps improve the dignity of the pay. But what they are saying is that during your time of studying or doing other things, you're losing income elsewhere, which other people like lawyers or other people with shorter courses would have done at that time. So put that pay there just to increase their pay, just to cover for that particular time. And two other allowances that. So when these were put, you're still in the same civil service job group category, but because of your uniqueness, your pay is higher. That brought dignity to pay for 10 years. Of course, when that pay does not change in 10 years, the guys who come in 2010 do not think that it's a big thing. And actually the union started from, why should doctors be earning this little amount of money? You see, for us who got a big pay rise, you know, I got a 4 times pay rise. At that time, I used to earn 10K. I started earning 40K. But you see, that's early, 2002, let's see. You see, for us it's big, but if you, 40K in 2010, with inflation and all that. So this union came with started with this poor pay. We can't be having read in school for all these years, and we are coming out to earn 40K. So they agitated and eventually transmuted and became the union. But that was facilitated by the 2010 constitution that now say that actually even the medics can actually have a union. And therefore the constitution was a big thing in this thing. Now, once that there was the constitution making process, we also put in the Health Service Commission with these nuances that were there. We actually, it's actually there. It was actually removed at the last moment, where they say, and the reason for that was clear, because you can't argue with the Teacher Service Commission. Why Health Service Commission? Because the Teacher Service Commission was already in existence. HSC was a new commission which was supposed to come and solve some of these problems, but it was put there. It was said you can bring it as a pass it as an act of parliament, but for the time being, to pass this constitution, let's relegate it to act of parliament, and therefore they put it out. But in 2013, when Mwai Kibaki passed the constitution, he actually passed it with the correct sort of devolution, and that's why we sort of went to court, which generally in principle was that national the national government would do curative health, which included all hospitals from dispensary till, and the county government would actually do preventative health, which would have helped in promoting medicine a lot, which is actually what now they are trying to go back into in terms of primary health. You see, all these things are big. And then health was actually devolved because the individual units were actually doing the medicine on their own. The smallest hospital was running itself and that. So then that passed. And then finally, we had three court cases on this devolution issue, because we said they did not interpret it the way we were to do. And then finally, the main thing, which maybe Dr. Mwachonda will touch on, the Salaries and Remuneration Commission, which was for us a big problem, because they were set up, and it's very clear, to set the salaries of state officers and advice on the salaries of public servants. Advice. Unfortunately, they started setting the salaries of public servants, and the state became suggestions, and that brings a problem. What is that problem? And now it even became worse in 2017, when a court of law said that their suggestion is law.
2015, during the Teachers Service Commission was not strike.
2015 they say that when SRC says, then that is like advice, then it doesn't become advice. So that kills the bargaining element for labor. You get, and that for us is the crux of the matter. So for labor issues, SRC. And finally, then came SRC now recategorized the way you band people in terms of, and I participated in the banding, and they went and used a grading system. And you were asking, how do you measure the work of a doctor, for instance? And they used a system that is mainly used to measure people who are seated down, who are making decisions for organizations. So if I'm sitting here, I'm the CEO, then the decision I make affects the whole organization, and therefore I should be in the highest job group, F. But if I'm down there doing the cleaning and sweeping, then it's a technical kind of thing. They forgot that in medicine, they don't have measures for saying, if I am in theater and I am doing technically a hard operation, all those years invested into it, and then for me to be able to do that operation in 2 hours as opposed to 10, there is nothing in that grading system. So we went there to fight that doctors be in the highest job group, not because they didn't have a measure of that. So we sort of put it at F, they put it at E, and even at one time tried to reduce it to a D. The grading is A to F. So those are big issues in terms of labor relations. But the reason we went to court is because they misinterpreted the constitution and devolved health without taking into account the factors that were used to generate that health devolution, which Schedule 4 again was the key, where the interpretation of what the National Referral Health Facilities was. As we are saying, National Health Referral Facilities was what was there in National Health Sector Strategic Plan 2, which is dispensary to level 6. But then they went and wakatafutilia what these national referrals and said is 2 or 3 hospitals. They kept adding, it became 4, 5, which was evident that So labor was managed by the Public Service Commission very well. There was labor portability. I worked in 3 counties before devolution, and in devolution I've only worked in 1 because I can't move. You get what I mean? And therefore my experience as a Kenyan becomes less, and you probably get it. And those were some of the nuances that labor are facing.
So having listened to both of you, just to try and bring it into context and actually link it, because if you look at what the pillars of UHC is, it's a well-trained, motivated, and efficient workforce. So for training, I think we've already discussed that in terms of the movement and the levels of training and who's supposed to. But unfortunately, it's still a subject of discussion between the national government and the county governments. There is, for the last 10 years, I'd say there's been positions that have remained constant. And we are not moving. When we say motivated, it's beyond pay. It's definitely beyond pay. And what do I mean by beyond pay? If you look at shortages across the country, inequitable distribution of health workforce, you don't have enough doctors in the facilities, you don't have enough clinical officers, you don't have enough even community health promoters. What the impact is that the person who's on the ground gets to work double or even more. And with time, burnout sets in. So now there's the issue of wellness. There's the issue of occupational safety and health of this worker. And then there's a work environment. Because you talked about how you work and then you have to go home, you have to balance. So the work environment, when you go to work, is it conducive for you? Do you have the equipment that is required? And if you look at the latest, the health facility census report by the ministry done last year, 2023, it's appalling because it actually shows a grave picture of our health facilities.
Throw in some numbers.
And so then now, with that in mind, that's motivation. So you're looking at the work environment. Does it allow me to feel that I am actually valued, that I can actually offer my services with very little stress from work? Because work stress is something else now that leads to mental health and burnout of the health workforce. And then that's motivated. And then efficiency. Efficiency comes with numbers. Efficiency comes with adequate training. Efficiency comes with performance management and how you're managed at that facility level and how the health workforce is management. So this now links to the 6 pillars, one being the governance and leadership of the health workforce. Of health generally, not workforce, governance and leadership of the health function. And then the issues that you've discussed, SRC, Public Service Commission, all these fall into the legal aspect. And from that, then now the labor part comes in, because the workers cannot be at work and still expected to try and resolve their labor issues, because the first principle is that they are employees, and any employee needs a body to advocate for their workplace wellness and employment rights and labor. And that's where the labor sector now comes in, with the unions coming in very strongly to do that. So looking at this and devolution, I only want to blame devolution really for the I don't want to use the word that would sound like the mess, but it is a mess in the health workforce, in the health sector, especially on human resources for the last 10 years. But are we as a country sitting down and putting all factors aside, all interests aside, politics aside, and looking at, okay, fine, we want to offer service to the common mwananchi for them to benefit, that if they go, we reduce the waiting time, we reduce the queues, as you say, we reduce the queues. They get a doctor or a healthcare worker who's come in not worrying about their delayed salary, not worrying about their loans or unpaid deductions, simple things that affect them at a personal level, and they're willing to serve you wholeheartedly because these burdens are not on their head. And so with that in mind, then what do we need to do? You see?
Exactly, because
even that's where now I'd like us to
exactly,
because to sum it up now in terms of
absolutely, because it's well and good for us to have conversations about the legal structure, and they're important because, as you say, we don't just show up at a hospital. No one shows up at any workplace just like that, right? There is some contractual obligation which is guided by certain legal processes, and those are important, fundamentally so, right? However, the heart of the matter is service delivery. So if you're talking about service delivery in a UHC context, right, then we have to look at it from a solutions approach, right?
Yes.
And so I'll give you some context before I throw it back at you to give us the answers. Because we have to start from somewhere, certainly, right? So I can empathize with, say, the county government, right? County governments, right? Because they're also saying, you know what, we perhaps understand better the needs of our county. So we want to have some level of control around the workforce that comes into this county, right? Assuming that they are guided by evidence. It's not going to be an element of I like you, interest, whatever it is. That's not it. It's they're guided by data. So they say, maybe we don't require more surgeons. What we require is more physicians. What we require is more obstetric gynecologists versus, what is needed in Turkana versus what's needed in Kilifi are two different, right? So I can empathize and understand why they would even take a hard stand and say, no, we know better. I mean, even in my own house, you're not going to come and tell me, let's have this. I know what I'm going to buy for my own house. So, end of story. So I can understand where they're coming from, right? I can also understand from a workforce perspective, whereby as human beings, there are certain basics that have to be covered, and those have to also be informed by certain evidence, right? And I'm taking a bit of time to just sort of summarize before I ask you the answers to our problems. Is this that other element of doctors are humans too, but so are police officers, so are teachers, so is anyone who's working is a human being, right? And I think the discrepancy has always been that doctors want to be referred to, at least from a public view, as they require preferential treatment, right? And that's not even the question I'm asking, because I think that becomes a factor of how we make the case, because we have to have a way of measuring that, whether it's the 7 years of school, whether it's the fact that there's risk and all these elements, those have to be captured in a format that then is translated to say, okay, it's not so much about just job groups and whatnot, there's more factors towards it. And this is why we need even a separate body that will advocate whatever it would be, HSC, whatever, that's a different conversation. I think the question now, coming to the question, is you've told me quality, right? Motivated, right? Efficiency, right? The human resource for health, the healthcare workforce, for them to render quality services, right? For them to be well trained. For them to offer quality services, they need to be well trained, motivated. So, where do you start? Where do you think? Because it seems like it's every other, as you're saying, 2 years, right? 1 year, another industrial action, right? Where
I like how you've summed it up, huh? And this is how I'd approach it. And there's precedence of efforts to try and cure this. Several efforts that we've been involved in previously. But let me put it broadly. You have county governments, you have the national government, and then you have the health workforce in the middle. And at the end, if you're traveling, so let's say on the highway, you have 3 cars all moving towards the destination is UHC, which is what? Affordable quality healthcare services to reduce out-of-pocket expenditure for the Mwananchi. And then you have these 3 drivers who all want to reach that destination, but each is driving in their own way. So how do we sum it up? The first thing was, what does the health worker want? They just want employment. When they're employed, they want a pathway, very clear pathway to go train and and advance their career. They want a conducive working environment. What are the counties saying? The county governments, they want autonomy, as you said, in terms of managing these health workers. What is the national government saying? That we are in charge of policy training. So there's the issue of resources. There's been that debate about resources, but I think where we are, first is what attempts have been made to try and cure this. One, the Human Resource Advisory Council that has been set up. It's advisory, which means it has no teeth. So basically, it has no teeth. What you advise which will not. It's not binding. You see.
Okay.
So what other mechanism? There was an intergovernmental Relations Technical Committee that was involved initially in the first 5 years of devolution, but then now it gave out the mandate with the Human Resource Advisory Council. Then the health workers are saying we want a central body to manage healthcare services that will standardize the management of human resources. And from where I sit, I think the only way is to create a central body to manage the health workforce standardly, so that if I want to move from county A to county B, because now that cycle back, if there's always entry, there's always exit. And that means then I can distribute you anywhere. So if both levels of government can agree on that, we have a body. Now, the body and its naming is a political issue, very strong political issue.
I was going to
There are options on the table. It can be a health service commission. It can be a health services authority. There are so many ways that it can be entrenched in law to make sure that it just manages the health workforce in a standard manner. That if I work in county X, I can move to county B. I earn the same amount of money and all salaries are paid at the same time, because one of the biggest challenges currently is the disbursement of allocations to counties. They delay for months. And then you ask yourself, the other day, the Council of Governors Health Committee Chair was noting that there's an effort to sabotage counties in delivering health services, and it's been like that for the past 10 years. Every subsequent chairman who comes in from the council, it's been like that. So 10 years later, we have to sit and ask ourselves, what can we do to resolve this so that we achieve universal health coverage? Because the commitment is there. I mean, so the government has hired 100,000 community health promoters. Then now what about the health workforce? There have been commitments before by the same government in Brazil, in the third global health workforce, to employ 12,000 workers annually between 2014 and 2017. That never happened. So currently where we are, the ministry talks of projections, gaps, training. They want to rationalize everything because the numbers have increased apparently. But all this, without political commitment, is just discussions and talk. And all this without a commitment to actually implement and employ health workers to achieve universal health coverage is just talk. So one is the body, two is the resources. I mean, we can't be slashing budgets for the ministry, for the health sector, and talking about universal health coverage.
We cannot.
We cannot be formulating benefit packages that basically just focus on the service and leaves out the human resource aspect. You see, we can't be doing that and saying we're going to achieve universal health coverage.
Artificial intelligence will solve it.
Yeah, precisely. Because I mean, I just saw a discussion today, someone saying that a family is allocated 2,000 shillings for dental, as dental cover.
A family.
So we're limiting.
A family cannot be one person.
We're limiting. We are limiting families to 4 to 6 visits to the hospital. I mean, who chooses sickness that I'll be sick 3 times? I'll need a CT scan twice or once in a year, you know. And all that still affected the Linda Mamba program that is now has now been dissolved, in the sense that the cost of a cesarean section was at 10,000. Without looking at it, would be a nurse will be needed, an anesthetist will be needed, a doctor will be needed to perform this. And that now boils down to the demotivation of the health workforce.
I tell you, we can go on and on.
So all these things are so intricately linked that we must have this sober discussion and entrench that and look at always the human resource angle of health services delivery.
I know. I hear you. I mean, it's, as we started, it's not an easy discussion, and it needs to be a continuous discussion, right? And we need to not only just engage stakeholders and policymakers, but also the public, right? And understanding that, yes, it's okay, as you said towards the end, that, you know what, benefits are there, but who's going to offer you those benefits? Because it needs to sort of sink in that whoever you meet on that other end, in many ways, is responsible for your life, right? And if I'm going to entrust my life to you, I want to be sure that you're going to take care of my life.
And I must be in the right state of mind to take care of you.
Absolutely.
Because if I am not, then chances are then
maybe we make this a mental health conversation. You know what? Forget labor relations. Let's make it a mental health conversation. And then we could. Kigondu. Final one.
So it is important to realize that of the 6 so-called described pillars of health, the most important are 2. And both of them are human resource related, which is first is governance, and the second one is the actual human resources for health. So in terms of the human resources for health, in terms of governance, it is important to put the right people in the right place for the right job. And these are based on qualifications. We have seen the human resources for health who are put in governance positions. Sometimes it now becomes a competition of sorts, as opposed to looking at what are the qualifications. And we have seen governance positions being put as one cadre against another, and these are very clever, typical strategies used to dissipate the governance. The
distractors.
They are not distractors as such. It's probably to eliminate the person who would have given the best advice based on qualifications, so that you have someone who can listen to the advice you want, or someone will tell you what they want. The second one is, I won't specify
don't.
The second one is that we need the as a country, and with looking at, they said what, Africa in 2064, we need to continue improving our services. At independence, we had no doctors. We trained doctors, and they came, and all the other issues. And we continue providing services which need specific skills. So we need, as a country, to continuously improve the skills and qualifications of the health workforce. And therefore, at the end of the day, we need to stop having policies like task shifting, task shacking, task sharing.
This terminology
so that we continue and part of the problem we are having in terms of human resources for health is following a policy where you think that someone who is less qualified, so to speak, can do the job of the more qualified, and then you normalize it. It can always be used as a stopgap measure, but when does the stopgap measure stop? The problem we are having in this country is making the stopgap measure the measure. And therefore, you have a simple example. You have governors saying that they don't need to employ a doctor. They can employ someone of less qualifications. They don't need to employ. I think doctors need to learn from what I think the Nursing Council did. The nurses had a problem with something called nurse aids, so to speak. And then when you start encroaching on the scope of practice of the other cadre, then you sort it out once and for all. You give clear instructions. So I think let's stop having poor quality medicine for poor Kenyans.
I think
final statement.
For me, we have very brilliant documents. If you read the strategy,
is the land of policies.
Strategy and policy documents we have when it comes to this matter of health sector workforce, they're just brilliant. They've been commitments. So for me, it's simple. Political commitment to soberly discuss these issues, put interests that are regressive in the agenda, and now focus on the commitment. So if we were to, and then the last thing I think is governments are in perpetuity. So if one government made a commitment, the next government must continue from where the previous government left. Because if we are going to go with each cycle 5-10 years, we come in as a government and we opt to do things differently because we don't agree with what was done previously, and yet what was done previously is very well entrenched in international best practices, then we're not going to achieve universal health coverage. So we stick to that and do it and implement it to the letter, the commitments and strategy documents and policy decisions, implementation to the letter, will achieve industrial harmony, which is important for universal health coverage.
Mwachonda, you'll have to come back. You'll have to come back. I mean, it's an important conversation that I think to achieve that commitment, we need to continue having, right? Because, again, there's also a perception we need to also change, right? Because fundamentally, this conversation, as we said, it's not this big terms, right? It's around how do we achieve universal health coverage.
Precisely,
And it's a factor of well-trained, motivated, and what's the other one? Efficient.
And we focus on the human aspect of the employee.
That's it, right? You'll come back again.
I'll be most obliged.
We'll continue having these conversations, and thank you. Oh, we need to bring the advisory, the health task force chair, Wafula. We need to bring him back. We'll see you next time. Thank you for joining the One Health Lens podcast.